Hi, good afternoon. Welcome to the American Foregut Society annual meeting of 2021. My name is Felicia Sussman, and I'm from Wall Cornell in New York City, and I'm so excited for us to be here today. We named this AFS 2021, We're Back Together, and we did that because there were so many obstacles, as you all know, in terms of us having an opportunity to sit together shoulder by shoulder to talk about things that are just so important to us and our patients and things that we are passionate about, both gastroenterologists and surgeons. And with that in mind, we welcome you all here to lovely Nashville and to this wonderful auditorium so that we're able to spend the next several days together enjoying absolutely incredible speakers and lectures. And we believe we've lined up a series of talks that will engage you and stretch you and allow us to have conversations that are deep and meaningful about the patients that we care so much about. With that, I'd like to introduce my friend and surgical colleague, Dr. Tom Watson, who I've had the opportunity to get to know so well recently. And you'll notice throughout the entire course that there is always going to be a gastroenterologist and a surgeon at the podium to be able to give both sides to all of the conversation.
Thank you, Felice, and good afternoon. It really is great to see everybody here as we get back together with a year off as a virtual meeting. It's great to get our second in-person meeting, and I look forward to the coming week. The program committee's been working hard on this agenda for the past year, and we think we've put together an outstanding program. Now, before we get started, I just want to go through a few housekeeping and logistical issues so that we're all on the same page about some of these things. Of course, COVID's on everybody's mind. The policy we've been told by the resort here is that everybody, of course, is vaccinated who's at the meeting. We ask that everybody in this room be wearing a mask except when eating or drinking or when up on the podium. We've given the podium speakers the permission to have their masks off. There are a limited number of AFS masks. They're pretty sharp. If you want to buy one out at the registration desk, they're available. For the speakers and moderators, we'd like you to present yourself out at the registration desk at least 15 minutes prior to your talk. One of the people at the desk can escort you back over behind these screens here, which is the speaker-ready area. And back there, they can outfit you with either a lavalier mic if you want to use it, or like we are, you can use the podium mic. I will say, though, that one of the issues with using the podium mic from this setup is that it's going to be hard to use a pointer from here. You have to use a pointer from one of the screens at your side, which will basically require a lavalier mic. We ask the moderators to come up on here at the stage at the beginning of the session. We also ask that we keep this on time. We've got a very busy agenda. We want to keep people in and out here in a timely fashion. There's a clock down here with a yellow monitor at 5 minutes and a red monitor at 0 minutes. We've also been told with special technology that if you run over, the lavalier mic starts administering electric shocks like an invisible fence and also self-destructs after 5 minutes, so you're encouraged to stay on time. We have left time for question and answers at the end of each session. We ask the question askers to be at one of the microphones. You'll see them in the aisles here. And please introduce yourself and where you're from. We want this, again, to be a chance to get to know one another, and the questions will be videoed. You see up on the screen here that the Wi-Fi password is Opryland 2021. There are headshots available out in the lobby over to the left. I've been told that those are free for AFS members and with a small fee for non-AFS members. Restrooms are out to the lobby toward the right. And finally, no big meeting like this can happen without the input from a lot of people. It takes a village, as they say, so I've got a great number of people to thank. First and foremost, I want to thank Kate Freeman, who's the executive director of the AFS. She's really been the one that has kept Felice and I and the program committee on task. She's been the one answering all the questions and the emails and the gazillion details that go into this meeting. And Rosaline Tully from Affinity Strategies, that's the company that helps put this all on, and their AV people. I think it's a beautiful auditorium and a beautiful job setting up, and we thank them tremendously. I want to thank the board and Reg Bell, the chair of the board, for all their work, the former president John Lippum, the current president Peter Krillis. Our program committee, who've worked really hard and a lot of hours together over the past year pulling this together. Again, Felice and I couldn't have done that without all the input of everybody, and again, I think we've got a great program this year. And last and certainly not least, I want to thank all of our corporate sponsors who, without their support, we could not have this event. I encourage everybody to attend the exhibit hall and some of the corporate lunches and dinners that are being sponsored. So that's all I've got to say. Welcome again to the meeting. And without further ado, I'd like to turn over the podium to the president of the AFS, Peter Kurlis, who's going to be giving us an update on the state of the society. Thanks again. Enjoy the meeting. I look forward to get to know all of you this week. Take care.
Thanks, Tom. Well, the lights are bright here, and I can't see any of you, but I'm sure you're there. So, Tom and Felice asked me to give a little update on the state of the society. This is our third annual meeting, depending on how you count. In terms of in-person meetings, it's actually the second. So welcome. Welcome live and in person. Here we are in Nashville. We didn't think we were going to make it for a while, because if there's one bit of advice I can offer all of you, it's don't try to have a meeting in the middle of a pandemic. It's definitely not a good idea. But we persevered, and in fact, the society is doing fairly well. We have in excess of 500 members at this point. It's a little slanted towards surgery, about a third GI, maybe. But we definitely need to encourage our GI colleagues to join to make this truly a GI surgical society. We depend on active engagement of our membership. This is your society, and I really encourage you to be a part of it, to get involved, to help make things happen. We are financially sound, but that's a blessing. That would be also thanks to Kate Freeman. She negotiated so many of these contracts. In fact, she's responsible for our contract here at the Opryland Hotel. This is the program committee. You heard from Felice and Tom week after week after week on the calls, trying to put this together and hold it together. These are the other members of the committee, and you see at the end there, Rosalind Tilley and Becky Circa from Affinity Strategies, who are our new organizers. And they are helping us here as well during this meeting. Sponsors. Sponsorship is essential. And these are our platinum sponsors: Intuitive, Ethicon, and Medtronic. Gold, CD Diagnostics and Endogastric Solutions. And then silver, we have a host of them. We depend on corporate sponsorships, and I encourage you all, as did Tom, to go visit the exhibits and express your interests in their offerings. So this is the organization as of 2021. I'm president. I'm president for another year. That was a COVID adjustment that was made. John Lipham, past president. Reg Bell, shadow president, and also president-elect. And Mike Smith, Dan Lister, Trip Buckley, and Felice. Now, one of the things that we've changed in the past year is we realized that this is not a static organization, and we have to develop a strategy for renewal. So we formulated a nominating committee consisting of the past president, past president, and current president, although right now it's Reg, and Phil Katz and Santi Horgan. And they are in charge of basically developing strategies to replace the leadership, as well as to have a natural turnover of the board. Speaking of the board, this is the current AFS board. Some of the names you've seen before: Reginald Bell, Trip Buckley, Ken Chang, Christy Dunst, Santiago Horgan, Phil Katz, me, John Lipham, Dan Lister, Joel Richter, Felice Schnall-Sussman, Mike Smith, and Lee Sustrom. Now Lee Swanstrom, sorry. The first work of the nominating committee was, in fact, to update the board and introduce two new members to the board, here, Carrie Dunbar from Dallas and Prakash Giawali from St. Louis. They are new members of the board as of now. Highlights of the year, I think a great accomplishment was getting onto the Fellowship Council. So this was a huge step, thanks to the efforts largely of Michael Awad and Christy Dunst. But the AFS is now a key player in the development of fellowships around foregut, certainly in surgery and hopefully in GI at some time in the future. The other enormous accomplishment of the last year was launching the journal. So the Foregut is the journal of the American Foregut Society. The GI editor is Phil Katz. The surgical editor is Brian Louie. And you see the editorial board as well as some international members, senior members, associate editors, and kibitzer Steve DeMeester at the bottom. Well, in a short period of time, not only did we decide to launch a journal, but we actually launched it. And this is from our webpage, and you can see that select an issue. There are actually 2 issues out at this point, and a third is imminent. This is a benefit to the membership, so you can access this through a little secret route on our webpage, but if you have trouble with that, ask me, because I figured out how to do it. Anyway, congratulations to Phil and Brian. No small accomplishment. The other big evolution was engaging affinity strategies to help us organizationally. This is an organization that does meeting management and organization management, professional organization management for organizations of our size. And you will see Rosalind running around here, facilitating things, and of course the AV and all that. So we have, I think, a very effective group of managers at this point. Not to belittle the old management, mind you. The old management was fantastic, but one has been replaced by many. And finally, I'll close out just by saying that we're going to do this again. We're going to do it again next year at the Gaylord Palms in Orlando. Those are the dates. Put them on your calendar, and I'll see you all there. Thank you. I was going to leave, but I can't because I'm moderating the next session here, so I'll invite John Lipham up here to join me. Well, you can introduce yourself, John Lipham, past president.
All right, thanks for that lovely introduction.
Okay. And we'll get started on the first session then. And let's see, I gotta actually.
You're introducing John.
Yeah, I know. I'm trying to get this to go forward though. So the first speaker is well known to me, John Pandolfino. He's the Hans Popper Professor of Medicine at Northwestern University. John has become a world authority on esophageal disease in general, certainly everything physiological about it. And we've asked him to address the topic of the genesis of GI symptoms in the foregut. Now, that may seem a bit strange to you, but John has gotten very involved in psychology as well as physiology. And as he talks about symptoms, I think you will recognize that. John, pleasure to have you.
Thank you very much. I think this is working. It is definitely bright up here, so I'm going to take my glasses off. Well, thank you very much. First off, I also want to thank Kate. Kate has done an amazing job with this and has really been on point with everything. And I just want to acknowledge her because she's made things very easy for many of us. I also want to apologize to Felice and Tom because I actually prepared the wrong talk. Originally, when I got the invitation, I was scheduled to talk about achalasia and EGJ outflow obstruction, so I quickly put my talk together, put it in a folder, and forgot about it. And then Felice emailed me and asked me to do a different talk, and I said, of course, sure. but I didn't remember, and I didn't prepare it until Monday night. But that being said, I find the topic that she gave me, symptoms in esophageal and gastrointestinal physiology, be a little bit more exciting. I think, the topic of achalasia and EG outflow obstruction will be adeptly taken care of by Abe Khan, so I don't feel bad about that. But I get to talk about a topic that I've been thinking a lot about, and I honestly, it comes from a lot of mistakes. And this is kind of a John Lipham-like talk, a kind of come to Jesus, where you spend years doing something and then you realize, it's not working. What do I do differently? And that's really where I'm at this particular point. And you notice, John, I'm walking now like you, away from the podium, talking about this. So I think it's a little bit difficult for me to discuss this topic in 15 minutes, though. And I think I have 13 and a half minutes left. And the reason for that is that there's so many aspects of symptom generation, whether or not you're talking about, the fact of bolus transit, retention, aspiration, all of these specific things. But when I really get down to it and I think about it, are we missing something, And there's kind of the 80-20 rule in everything in life, right? And I think that we've done a really good job with the disease states that we're dealing with. Achalasia, we understand why people have symptoms with achalasia. They can't eat, things get caught, but we've been really chasing these other kind of unicorns or, these very subtle defects in motility. Like, is the wall too stiff? Is there a subtle obstruction? Is there this visceral hypersensitivity? And we've been chasing that. I don't know if that's the right thing for us to do. And if you think about the incremental benefit of going after that, is it really worth it? And then, this idea of visceral hypersensitivity, it's fascinating in a pathophysiologic way, but how relevant is it to clinical practice and how we deal with it? And then I get back to what Peter alluded to, my focus now more on the gut-brain interactions. And how does our underlying stress, hypervigilance, and visceral anxiety come into play when we think about symptoms? So one of the things in the context of this phase, and I love this slide because to me, it's a miracle that you can eat a piece of food, chew it up, swallow it, and it makes its way into the stomach. It has to, within a second, go through the upper esophageal sphincter, navigate around the trachea, the spine, the heart's pumping. I mean, it's pretty amazing. Then the esophagus dives through the diaphragm that's moving up and down, and we just, expect that this piece of food is always going to make it down. So there's a lot of places where things can go awry. So when you think about esophageal symptoms, the transit symptoms, to me, are the most fun. So I come from a long line of plumbers. Half my family are either plumbers or electricians. And I like to think of myself as a very sophisticated plumber. And, when you think about bolus transit, you're just trying to make sure that there's good propulsion, and you're trying to make sure that there's no obstruction. And then, of course, if you're thinking about reflux, you don't want any backwash, right? And I think that those symptoms and the deficiencies that are related to the physiology that cause symptoms related to transit, those are the fun things. They're kind of easy to fix most of the time. Where we probably get into a lot of trouble is more the perception related. I don't think we have a great handle on that. I'm not going to really talk too much about the perception related disorders like chest pain, heartburn, and these thermal sensations, because we really haven't gotten any further over the last years, although I do think that there's some great people like Dan Sifram who are working on this and will have a lot to add. But one of the things that I think is really important is fear and hypervigilance. These are the symptoms or the constructs that are really important to the patient. When they're sitting at home and thinking about their swallowing and whether they're going to choke and if there's anybody home to help them, they worry about going out to dinner and being embarrassed with their family. That's really what drives symptom severity and quality of life, and I hope to prove that to you. So as I mentioned, certainly in the context of swallowing, and that's what I'm going to really use as my platform, there's no big surprise why this person has symptoms. I mean, nothing's getting down. They're literally going to drown on their saliva and the food that they ate earlier that evening, especially if they're laying flat. And it's not to belittle or say that, swallowing and these disorders don't have relevance. I mean, we do swallow over 1,000 times a day and we don't even think about it. And it's kind of like breathing if you think about it. You breathe all day, but the minute you can't breathe or you start to get short of breath, it's disconcerting. Well, the same thing happens when you swallow. You take it for granted all day. You're swallowing your saliva, you go have a meal, and then the minute it doesn't work, it freaks people out. And they worry about it. They're like, am I going to choke? Is this going to be embarrassing? Do I have to run to the bathroom? So it's a pretty significant issue. And that fear drives a lot of the symptoms. But certainly I think, we know that these particular symptoms do have significant comorbidities associated with them. There is the issue of malnutrition, aspiration, and cancer and death, and those need to be considered when you think about this. And that's why I think being careful and being aggressive with screening people and surveillance really puts people's minds at ease. So for instance, when I see a patient with Barrett's esophagus and they come to see me and they're worried about cancer, I tell them, listen, you already did the most important thing. You came and saw us, you got the diagnosis. Now we're going to watch you like a hawk and you're not going to die of esophageal cancer. And I can confidently say that to patients. And when you give them that piece of reassurance, their symptoms get better. So now, in the construct of symptoms, I will tell you that when I see people in clinic, regardless of whether they have heartburn, regurgitation, dysphagia, chest pain, food impaction, your differential diagnosis is pretty vast. And you can think you're a great clinician and say, I think this person has EOE because it's a young male with solid food dysphagia, and then you scope him, it looks like achalasia. But all roads lead to endoscopy eventually, right? And I still think endoscopy, I love physiology, but I still think endoscopy is the most important test and the most important tool we have in esophagology. And as I mentioned, you scope someone, see erosive esophagitis, you see a piece of food stuck there, you see rings, it's not a big, question of why they have symptoms. They have an obstruction. The pipe is clogged. They can't get things down. So that's not a mystery. But probably what happens more often when we see these people is we scope them, we go in there, there's nothing there, we tell them we didn't find anything, and they're disappointed. And they still have symptoms. And that's even more frustrating. Now, we do have a lot of great tests, and I'm not going to talk about them. You're going to hear a lot of great talks over the next few days about manometry, FLIP, and esophagram. I'm actually moderating the next session with a couple of good talks on esophagram and FLIP. So I'm not going to go into too much detail, but these, when they're blatantly abnormal, they explain symptoms. There's an obstruction, there's spasm, there's bolus retention. Sometimes we're even lucky when we can actually find a motility finding that actually matters. This is a patient who was the first patient that I saw that I called jackhammer esophagus, and she would literally have these squeezing spasms in her chest and have that pain. We eventually treated her with a POEM. Started out with Viagra, that she wanted to have kids, didn't want to take Viagra, and we did a POEM. She's still doing great, and this is probably like 8-9 years later. But probably when you really think about it, and we talk about symptom generation, we don't talk about the easy stuff. We talk about the patients who have a negative test, they have a negative manometry, maybe they have a little bit of hypersensitivity on their reflux test. They have a symptom reflux correlation with a symptom index that's a little bit positive. And these are the patients that kind of really drive us crazy. And the problem is that when we look at all of these fancy tests that we have, once we get away from the major motor problems, these tests, they don't help us. We have yet to find a really good clinical correlate with any of these motility, impedance, FLIP. We could show you that functional dysphagia patients look a little bit different than controls, but we really can't correlate anything or find an outcome to really target. And that comes to this paper. And I think this was a pretty important paper, at least in my career and thinking about disease states. And this was actually a multi-center study where we went and looked at high-resolution manometry, and we actually looked at symptom severity. And what we found was that the actual thing that was driving symptom severity was not any motility metric. It wasn't DCI, IRP. It was their esophageal hypervigilance and visceral anxiety. So these two groups here, I can't use the pointer here, but you can see them. One is a group with major motor disorders, and the other is a group with minor motor disorders, or normal. And the thing that actually predicted or showed that they had worse symptoms was their EHAS score. And really that gets to what hypervigilance is and visceral anxiety. These are things that actually make patients' symptoms worse and affect their quality of life. So essentially, hypervigilance is the tendency to focus on physiologic things, or things that are really not probably that important, where symptom anxiety is worrying about that. Am I going to be able to eat this meal tonight in peace? And there are all these cognitive affective processes that kind of come into play with this, that really target this interaction between being hypervigilant and having visceral anxiety and what happens with their symptoms. And we've looked at this in multiple disease states now. So these are some paper in EOE that was just recently published. And what we found was that when you looked at the BED-Q, the only thing that actually mattered in terms of symptom severity was the EHAS score, the visceral anxiety. If you use a different symptom score, the EESAI, the same thing. And this was actually modeling in EO count, flip distensibility. The only thing that mattered was visceral anxiety. Well, what about GERD? Well, this is an important slide because it gives you this idea of this construct of this evolving pattern of acid exposure and hypersensitivity and this kind of construct of organic to functional disease. Well, I'll tell you that dogma doesn't really hold. And once again, if you look at reflux, symptoms don't track with the number of reflux events, how high they go. It tracks with visceral anxiety and symptom perception. And that has been started to be reproduced in multiple centers across the world. This EHAS score is being translated to Spanish, French, different languages, and even China. They can show you that the thing that drives symptoms is visceral anxiety and hypervigilance. And really that gets back to this idea of how we talk and how we think about symptoms. And really what we should be doing now is using this framework of a psychophysiologic model of GERD. Now the disease gets patients in the door. If I can't eat, I'm going to see a doctor. I need an endoscopy. If I'm having horrible reflux, I'm going to see someone about that. I'm going to walk into the door. But think about how many times you fix the plumbing. The plumbing looks perfect, and the patient is not well. Their quality of life is still poor. Their symptom severity is still significant. That happens all the time. In fact, we have a paper that we're working on right now looking at achalasia, where you can clearly see that we have effectively treated achalasia extremely well. But some patients just do poorly and some patients are doing well. And the distinguishing factor is their EHAS score. How hypervigilant are they that things may get caught? How worried are they that things are going to get caught and they're going to choke to death? That's what actually drives symptom severity. The pathophysiology is still important. As I mentioned, that's what gets them in the door. That's what starts the journey. But where the journey ends is in the brain. So I could punch you in the stomach. If you don't have a brain, you're not going to feel anything, right? It's all how patients perceive the stimuli or the threat. And I think that's really been the missing part. So when I think about all of the time I've spent chasing wall tension, intrabolus pressure elevations, stiffness of the wall, subtle obstruction, these odd patterns, ineffective esophageal motility, I've come up short. But I will tell you that when you look at this psychosocial model, I think this is really the key. And I think this is what we really should be doing. We should be addressing these symptoms as we treat these patients, even before we send them for interventions. Because if we do this appropriately, they will have better outcomes. So I think I'm at my 15 minutes. Thank you for indulging me and letting me talk about psychology at an American Foregut Society meeting. Thank you very much.
Nice talk, John.
See, I'm modeling myself after you.
Nice job.
All right, well, thanks, John. That was fantastic. It's my privilege and honor to introduce Dan Lister, who's a good friend, one of the co-founders of AFS, on the board. You're coming up prematurely. I was going to give you all sorts of kudos. Did his training at the University of Arkansas. Then went on to do medical school, Marshall University, or residency there. Like I said, tremendous contribution to the area of foregut. He went back to Arkansas to set up practice, small little place, Heber Springs. Now the good thing about Arkansas, if you're not familiar with Arkansas, is actually everyone in Arkansas has reflux. And so even though small town has been able to build an incredible foregut center. So Dan's going to talk to us a little bit about the barrier to reflux. Dan, now you may enter.
Thank you, John. Thank you. Great to be here in person with everyone. After this past year, this is great. So I want to talk a little bit about the physiologic and structural defects in hiatal hernias. Here are my disclosures. None of them are relevant to this talk. So hiatal hernia, very common finding in patients with GERD. In this study, 50% of patients with hiatal hernias had esophagitis, and the vast majority of the patients with esophagitis had a concomitant hiatal hernia. And there was a very strong association between esophagitis and hiatal hernia. Endoscopic and radiographic studies suggest that 50 to 94% of patients with GERD have hiatal hernias, where if you compare that to controls, only about 13 to 59% of patients have hiatal hernias without GERD. And this brings us to the two-sphincter hypothesis. So Robbie Mittal's group looked at this with high-definition cross-sectional imaging of fresh cadavers, and they did 3D reconstruction, and what they found was a pair of nooses. The first being the LES, where the circular muscle fibers cross at the angle of His to form a sling. The second noose was the crural diaphragm, with the right cruce being the major component of this. To take that a step further, Brian Louie's group did an interesting study where intraoperatively, after dissecting out the hiatus to do a fundoplication, they did high-resolution manometry after the dissection. And then they looked at the different components of the repair, either the wrap or the hiatal closure. And they found that statistically there was no difference in the increase in length between the hiatal hernia repair and the Nissen fundoplication. But interestingly, what they did find was that the pressure barrier component was very significantly shifted towards the crural closure, with 10 millimeters of mercury coming from the crural closure and only 3.5 millimeters of pressure coming from the Nissen. So the barrier is more than the LES. For years we have been preached and taught wraps and pressure and transient lower esophageal sphincter relaxations, and maybe it's not that. Maybe it's more of another problem. And this study out of Cornell, very interesting study just recently published. They took 100 consecutive GERD patients, 45 Nissen, 44 toupees, and 11 links. And they did endoflip, and they looked at various components of the valve. And they found that 80% of the cross-sectional surface area and the DI, and a 60% increase in the high-pressure length from the repair of the crura. And then they looked at across the 3 different surgeries, and there was absolutely no difference between Nissen, toupee, or links. And what they concluded was that the overall hiatal hernia repair accounted for 80% of the benefit that you got at the LES. So what goes bad in GERD patients? Are the crural abnormal? In this study, they looked at anatomic and functional deficiencies in the crural diaphragm. They had 20 reflux patients with fairly mild reflux, 9 with hiatal hernias, 11 with no hiatal hernias, versus 43 controls. They did high-resolution manometry and endoscopic ultrasound, and they measured both the crural thickness of the right cruce and the crural contribution to the barrier. And what they found was that the crural contribution in GERD patients was lower, statistically significantly lower, and that the right crural diaphragm was thinner in the reflux patients as compared to controls. And they decided that this was a functional deficiency of the crura in GERD patients. So is there a structural problem here with the muscle? John has mentioned this study before and how they got it by the IRB. I tried in Arkansas, and even as backwards as Arkansas is, they still wouldn't let me do it. But what they did was they did laparoscopic sampling of the crura and the phrenoesophageal ligament. And then they analyzed those samples with transmission electron microscopy. And they took 33 patients with GERD and hiatal hernia, positive pH, relatively small hernias. They excluded paraesophageals. They excluded large or recurrent hiatal hernias. The tricky part was the control group. So you can see biopsying hiatal hernia repairs, but their control group was lap gallbladder patients. So you're in doing a lap chole, you take a right-hand turn, and you go up and you biopsy the crus. So don't know that I could get that by my IRB. But they looked at the different structural defects in the crural muscles, and they graded those from dilation of the intermyofibril spaces all the way up to extended degradation of the muscle fibers. And what they found was in the GERD and hiatal hernia patients, 94% of the patients had a muscular abnormality of the crura, and 75% of them had a severe abnormality. There was no difference in the phrenoesophageal ligaments, and when they looked at the control groups did not have any abnormality of the crura or the PELs. So if that wasn't good enough, they revisited the study and did it again a few years later. This time they branched out a little bit and didn't just use lap gallbladder patients, they used appendix and splenic cyst patients as their control group, but found the same thing, that 90% of the patients had a structural abnormality of the muscle, 75% being severe, and the lap gallbladder, the appy, and the spleen patients did not have any abnormalities. Could this be a connective tissue disease? In this group, they looked at the collagen makeup of the phrenoesophageal ligament in 29 patients with hiatal hernias and 32 cadavers that did not have hiatal hernias. And what they measured was total type 1 and type 3 collagen. And they found an interesting finding in that the total collagen as well as the type 3 collagen was significantly decreased in the hiatal hernia patients. So, you know, we're dealing with bad tissue anyway, and this may be an explanation as to why we have such a hard time getting a hiatal hernia repair to stay repaired, and why we have a high recurrence rate. So this may be a genetic problem in that same area. This group looked at collagen type 3 alpha 1, which codes for type 3 collagen. And it was a database where they queried on patients with reflux and in familial clusters that had reflux. They had adults and pediatric patients. And they analyzed these genes. And what they found was that the hiatal hernia patients had a chromosome 2 defect that coded for type 3 collagen. The crura has also got neuromodulation that may be part of the issue. In this study, they looked at vagal, both sensory and motor neurons that functionally innervate the crura. The vagus nerve also innervates the crural and the distal esophagus. And this may be an explanation of why we have TLSERs, where in the study, if they blew up a balloon in the distal esophagus, the crura relaxed. If they blew up a balloon in the stomach, the crura tightened. But what happens with reflux when you get reflux into the distal esophagus, which then in turn dilates the distal esophagus, and you get a relaxation of the crura, which may explain TSLERs. So why does all this matter? Why does anti-reflux surgery fail? This group looked at recurrence patterns after hiatal hernia repairs They had 284 patients with recurrent GERD, and they followed these for a median of 10 years. And they looked at, was this a disruption of the wrap, or was this a recurrence of the hiatal hernia, or a slippage of the hiatal hernia, or a slippage of the wrap into the hiatal hernia? And what they found was that 14% of the patients had an intact hiatus, and almost 86% of the patients had a hiatal hernia recurrence. And we've got to do better than that. So we've got to figure out some way that we can get that hiatus to stay repaired. There are different types of hiatal hernias, and everyone in the room knows this, but just to go over it, type 1 is the classic sliding hiatal hernia, type 2 is the true paraesophageal, type 3 is a combination, and type 4, of course, you have the pancreas or the spleen or the colon up in the thorax with the stomach. And one of the things that we talked about yesterday in our advocacy summit was the importance of documenting in your endoscopy note what type of hiatal hernia you have. And the story that was told yesterday was a patient had been reported as having a hiatal hernia, a sliding hiatal hernia by the endoscopy note. Well, when the surgeon got in there, they had a type 3 paraesophageal. They coded it as a paraesophageal hiatal hernia repair. 6 months later, the insurance company pulled the op note from the endoscopy and denied the paraesophageal hiatal hernia repair because they said that the surgery was pre-certed as a regular hiatal hernia repair. So it's really important that you correctly diagnose and document this on your endoscopy records. And it's very subtle. On the left-hand side of the screen, you see what is a type 1 hiatal hernia. So the crural diaphragm opening, the scope coming through, and the highest point in that hernia is the LES. So that's a type 1 hernia. On the right, you'll see that you have fundus of the stomach above the LES. That's a type 3. So if you pay attention to that and you document that appropriately, it makes it much easier on the surgeon later on when they're fighting with the insurance company on trying to get that surgery approved. Endoscopy of the GE junction. I think this is very important for patients or for GI doctors, especially as they start doing endoscopic repair or TIF. So as you can see here, you've got a Hill 3 valve. If you take only 6 or 7 seconds to retroflex and look at this, you may miss the true problem here. And we found this early on in our TIF experience, that we missed a bunch of hiatal hernias. So by inflating the stomach, retroflexing the scope, and then pulling up into the hiatus to simulate what happens when the patient goes to the all-you-can-eat buffet and overloads their stomach, you'll find that the radial separation of the crura is much higher than what you initially thought of. So in this, what I call provocative endoscopy, you've pulled up into the hiatus, and when then you go back and look, you see a much bigger defect. And if you're going to do TIFs, you've got to make sure you diagnose this, because if you try to do a straight TIF on this patient, it's going to fail in about 6 months. As the valve traverses the hiatus, it's just going to slowly pull itself apart. So in summary, hiatal hernias are extremely common, and that the crura plays a key role in the anti-reflux barrier. It can be both a connective tissue or a genetic component of this problem, and that the failures of anti-reflux surgery are a failure of the crural repair. Take time to identify hiatal hernias in your endoscopy records, and pay special attention to this if you're going to go on to endoscopic therapies. It's not as much of a big deal if someone's going to surgery, because when we get back in there surgically, we're going to be able to see the hiatal hernia. But if you're trying to do a TIF on these patients, you're going to have bad results where the patient needed to have a hiatal hernia repair and a concomitant TIF, and you missed the hiatal hernia on your initial endoscopy. And accurately characterize these hiatal hernias in your endoscopy report. Thank you very much.
Thank you, Dan. I failed to mention that Dan was also a DJ, apparently, going through high school, college, something. That is a fact. You can write that down for trivia later. Oh, med school. Apparently you can pay for med school by being a DJ. Well, it's my great pleasure now to introduce Dr. Ravinder Mittal. Most of you, or many of you, probably know him. I definitely know him. I sort of secretly stalk him, not in a creepy way. I mean, not real creepy anyway, but I have followed his work for decades, and looking at the barrier, his contributions to understanding the crural component of this. Robbie is professor of medicine. I almost said professor of surgery. That would have downgraded you a little bit, wouldn't it, Robbie? But professor of medicine at University of California, San Diego. He's in charge of the motility program. Just an absolute stellar individual with, like I said, huge contributions, and somebody I idolize. Robbie, it's all you.
Good afternoon, gentlemen, and thank you. Thank you for this kind invitation. And I'm glad I really don't have to speak about the symptoms, because that's the bane of the problem in esophageal disorders. I have no conflicts of interest, and how do I advance this thing is go forward. So a couple of years ago, I read this magnificent book, Leonardo da Vinci, by Walter Isaacson. We all know about his Mona Lisa, and most of you probably know that he was doing dissections, cadaver dissections, secretly in the basements. He had a mask for different reason on his face, stinching cadavers. And he drew some beautiful, beautiful 3D images of the anatomy. And Walter Isaacson wrote at the end of the book that Leonardo da Vinci has done a lot of things with machine. He illustrated body parts using exploded views, multiple angles, and sagged up layers. And he studied the movements of the various muscles and bones. I don't want to read the whole thing, but in summary, what he was doing was he was trying to predict function from the structures. He was an engineer, and he had drawn a lot of engineering tools, and his interest in anatomy at one stage in life was to predict function from these structures. Now, I come back to 1958. This is a beautiful physiologic review articles from Franz Engelfinger, who was one of the best in the field. And this is a 52-page review, and 23 of these pages are devoted to the lower esophageal sphincter, 289 references. And this is, I think he understood the importance of the lower esophageal sphincter then. And this is not what he says, this is what I say, that an incompetent sphincter leads to reflux, and overtly competent sphincter leads to achalasia. And I'm reaching out maybe a little bit, but not too much, when I say most of the benign and even some malignant disorders of the esophagus, Barrett's and adenocarcinoma, are really due to the dysfunctional lower esophageal sphincter. So he knew it. He was a great guy, and I think he was the Peter Carillus of that era, and even better, John Pandolfino. So what was he saying about the lower esophageal sphincter in 1958? He said 3 structures are important: crural diaphragm, flap valve, and the smooth muscle lower esophageal sphincter. Now his problem though was, he said, yes, I know these are important, but I really don't have the good techniques to prove them. And then he said, the nicest function phenomenon lacks morphological basis. So what he was saying that function does not match with the anatomy of the region. So he was puzzled after writing this huge article. I read it 15 times. And I think to this date, he wrote everything what was there, but he didn't have the right tools to prove them. So I look at this 60 years later, this beautiful review, and we're talking about the same three structures. We're talking about the lower esophageal sphincter, we're talking about the crural diaphragm, and we're talking about the flap valve. But I think we have a better understanding of these structures than Ingelfinger had, what he was talking about and what he was struggling with. And this has to do with the techniques that has developed to measure this sphincter function. And I think since 1950s, at least since 1950s, Charlie Code, we have had the advancements every 10 years. Every decade, we have improved the technique to measure the sphincter function. From open tip catheters to infusion manometry to sleeve sensor, and so on and so on. And the latest one is the 3D LES pressure manometry. And I'm going to show you 3D LES pressure manometry because it captures everything else that all these other techniques had captured, and this adds more than these other techniques had captured. So this is the Peter Carrillas paper, Kwiatek and Carrillas paper. First time they looked at the 3D function of the lower esophageal sphincter using this 3D manometry catheter that had 12 ring-like electrodes or pressure transducers, and each ring had 8 sensors 45 degrees apart. And what they could see in real time continuously, this pressure profile of the esophagogastric junction region. And there are a lot of things in here that we knew before, but there are few things that we learned more from these recordings. So you can see that these pressure profiles are not the same color. They have different colors. It means the pressure varies everywhere. It's not the same pressure. There's no magical number on the sphincter pressure. If you look at this, all these colors means different pressures. So what is the normal LES pressure? So we knew about that this asymmetry, the sphincter is not symmetric. We knew that the crural diaphragm, at least based on for the first time, we found out that the pressure generated by the crural diaphragm is also not circumferentially asymmetric. What captured me the most was that the high pressure zone is longer on one side compared to the other side. The difference could be twice on the right side versus left side. It is shorter on the left side as compared to the right side. So the sphincter has so many angles, but at least this technique can capture many of the features that we were trying to capture for last 60, 70, or 100 years. So we got, after that, to learn more about this high pressure zone, and what we did was, one of the problem in this recordings is when you have the recorder in the subject, you really don't know which sensor is facing which side of the subject. So to conquer that problem, we put a metal ball on sensor number 1 of the transducer. And then what we did was, once we had the metal ball, we got a CAT scan. Because with the CAT scan, you could figure out the circumferential orientation of the sensor. And the way these 96 sensors are sitting on the catheter, then you know each sensor where is sitting in the anatomy of that high pressure zone. So this was the technique we used to figure out the orientation. And this is the data that we got. This is the mean data from 10 normal subjects. So there are 4 color plots here. I'm sorry, I don't have the pointer to point you out. But if you look at A, the shape of this high pressure zone is very reproducibly just like an underwear. If you look at 9 o'clock position and you go to the picture on the right side, 9 o'clock is towards the lesser curvature of the stomach. The sphincter is much longer towards the lesser curvature of the stomach. It's much shorter on the right side, on the left side. Now, the picture B shows you the post-swallow and expiratory pressures, which is when the LES pressures, smooth muscle LES pressures are higher. And it again shows you the longer sphincter on one side compared to the other side, and wide variability in the pressure. Pressures are higher on the left side and towards the posterior region. So there is marked asymmetry. Then on C, you see tidal inspiration, where the diaphragm is contracting. Where does the pressure increase? That's in the top half of this high pressure zone. And D is with the forced inspiration, where the pressures are really high. The scale, I had to change the scale to capture all the pressures. There you see the pressure profile from the hiatus or the crural diaphragm. The pressures from the hiatus can go 100, 150, 200 millimeters of mercury when you take a deep breath. And that pressure profile is horizontal on the top part of the pressure profile. So this is what we figured out. This is where the smooth muscle sits in the anatomy of the esophagogastric junction. It is not like a cylinder that is normally drawn in the pictures. It has a very unique shape, and this is how it sits in the anatomy of the esophagus and stomach, and this is where the crural diaphragm sits in the anatomy of the esophagus and stomach. So one of the questions Peter asked me a while ago was, how can you show that this pressure profile from the hiatus is horizontal? The hiatus is not a horizontal structure. Hiatus goes like this, anatomy goes like this. So how can it produce an anatomy like this, produce a horizontal pressure profile? And the answer to that is the catheter. As the esophagus enters into the stomach, catheter makes a right angle. And this right angle creates the horizontal or 90-degree orientation between the hiatus and the catheter, and that gives a pressure profile which is perfectly horizontal. So I'm going to tell you a little bit more about the microstructure of the sphincter, because that has dodged so many investigators. And this is not dodged in recent years. Since 1674, descriptions in the literature of cardiac loop of Willis. Then in 1719, collar of Helvetus, that a sling-like muscles coming from the top of the esophagus down along the lesser curvature of the stomach. Then Lieberman Meffret really made a serious attempt to understand the microscopic structure, and this is what she came up with. This is in the orange here, and she came up that sphincter is composed of the semicircular fibers in the top, and then towards the sling fibers on the other side, and then there are other fibers, these clasp fibers, on the lesser curvature of the stomach. So this was a complicated anatomy to understand, and this actually has been confirmed by other people, in this case Zendis, that the anatomy of the smooth muscle LES is just like that. So what we found, interestingly, this paper in 2010, this was a beautiful paper with beautiful images. What these guys from New Zealand had done was gotten a 4-centimeter specimen from a live, not from a live, but recently died person, and they did cross-sectional images every 50 microns, they stained the surface, and then they had 652 axial sections from this 4-centimeter specimen. Each section was 25 megabytes. And when they were looking at, they didn't have the computer power to put all these 652 sections together. And they came up with this structure that didn't make sense to me. I said, can I get that? It took me 6 months to get those images, took me 2 years to put them together, and then we finally came up with this structure of the smooth muscle lower esophageal sphincter. So I'm going to take you layer by layer. This has some beautiful anatomy to demonstrate. This is the innermost, or the mucosa of the esophagus and stomach, and this is the innermost layer of the esophagus in green. And the sphincter muscle has a unique anatomy. The circular fibers cross at the angle of fist and then continue as the sling fiber. So sling fiber is not a separate structure. It is part of the LES. That's what I'm trying to tell you. Then these clasp fibers that Dorothy Meffret was trying to, or had seen, are there. The clasp fibers are there, but they attach from one sling to the other. They are inserted into the sling. The circular muscle fibers of the stomach are inserted into the sling. They don't go around the whole stomach. The longitudinal muscle fibers are same. They are inserted into the sling fibers. And the longitudinal fibers of the stomach, they originate from these sling fibers. So this has a beautiful anatomy, some very unique anatomy. So we haven't published it yet, but we have enough data that you can confirm this on the human specimens. And I'm going to show you an example of that. This is an everted stomach. So you're looking at the inside of the stomach, and you can see the sling coming from the angle of his down structure. And if you do a histological sections, you can see the orientation of these fibers. So I'm going to show you one from the box number 1, a cross-section across a sling. So this is the cross-section from fiber number 1. And you can beautifully see the clasp fibers merging into the sling on the right side, and the circular muscles of the stomach merging into the sling. You can see the longitudinal muscles. So the sling is a very unique structure. You know, collar of Helvetus, cardiac loop of Willis, innermost oblique layer of the stomach. This is a very unique structure. It is almost like an attachment of various muscles in there. So based on what I think, now we have a nice function that matches with the morphological basis of the lower esophageal sphincter. So this is where I showed you. This is where the LES is in the anatomy. This is where the crural diaphragm is. And I'm no Leonardo da Vinci. This is my illustration of how the fibers. So the muscles only have one thing they know to do. All they know is to shorten. And when they shorten, depending on the architecture, whether they're going to generate a linear force or a constricting force depends on the architecture. So this type of architecture makes that high pressure zone. So it's not a ring or a donut, it's a purse ring. And same thing is true for the hiatus. Hiatus is not like a ring muscle. There is a crossing of the fibers at the posterior, and then there is a crossing of the fibers at the anterior. It's a double noose. So, you know, the dictionary diagram of sphincters being circular, donut-like muscle is not correct, at least for the sphincters of the humans. So I'm not going to talk a lot about physiology because I only have 15 minutes. Dr. Goyal's work for last 30, 40 years have really revealed some very unique things about the smooth muscle lower esophageal sphincter. It has myogenic tone. It modulates with excitatory inhibitory nerves. It's a gold mine of receptors, but what they do, nobody knows. Vagus nerve causes relaxation. Sympathetic nerve causes LES contraction. And this is what I was trying to record back in 1987, almost hate to admit it, 40 years ago, 35 years ago, using the electrode sleeve sensor, the function of the crural diaphragm. But there were problems with this technique. The sensor didn't have high fidelity. So I really had to come up with some creative ways of monitoring it. But now, with this high resolution manometry, you really have the technique. You can monitor the function of the crural diaphragm very easily. And you can actually record the EMG signals also. You can use the same impedance electrodes for impedance to record electrical signals, which we are doing now. And you can get beautiful, beautiful function of the crural diaphragm using this high resolution manometry and EMG recordings using these impedance electrodes. So this is some of the functions that we have figured out over the years, that the increase in the sphincter pressure with inspiration is due to the crural diaphragm. The amplitude increases related to the depth of inspiration, force of diaphragmatic contraction, and it also contracts with other maneuvers like compression, straight leg raise, coughing, Valsalva. So any maneuver that increases your abdominal pressure brings the hiatus into contraction. So why is it important to understand that? Sphincter is a very dynamic structure. It has to be, because it's guarding against pressure gradients between the thorax and the abdomen. And these pressure gradients are changing every second. When you talk, when you cough. So that's why the sphincter has to increase or adjust to these pressure gradients. So this is what we think. End expiratory pressure is due to the LES, but only in the resting state. And if you increase with inspiration and other maneuvers, then the hiatus comes into action. And if you ablate this high pressure zone, just like during transient relaxation, that's when you have reflux episodes. And not only you have to ablate the LES, the crura has to relax as well for the reflux to take place. So this barrier and gradient function, which is not being tested this carefully, I think is very important to understand the pathophysiology of reflux. Now, what about the last thing, the flap valve that Engelfinger was talking about? And this is some of the images of the flap valve, especially the grade 4 valve. To me, it looks like hiatus hernia. I had a lot of trouble understanding how could a flap valve help with the high pressure zone. And to date, I don't. What I do understand is this may be looking at the hiatus hernia from below, because that's what hiatus hernia looks like from above. And this creates a very unique anatomy. You have now many compartments. Once you have the hernia, you have many compartments with gradients, different pressure gradients, and different sphincter pressures. So this is with the high resolution manometry. Tidal breathing, if you look at the sphincter, it increases with each inspiration. And with the deep breath or a Muller maneuver, the pressures can be 150, 200 millimeters of mercury. So this is a very dynamic sphincter. This is not pressures of 10, 20 millimeters of mercury. So I'm going to show you a recent observation from sliding hiatus hernia. Everybody knows hernia is important in reflux disease. And what we think that this is a two-step pressure pump of reflux. This is really very important. And this concept, what does this mean? So in the normal, the two anatomical structures are sitting on the top of each other, LES and diaphragm. But in hernia, now you have LES sitting on the top, and the diaphragm sitting a little bit below, and you have a hernia in between. So what happens in a hernia situation if you take a deep breath? Well, Piracrillis and Pandolfino had actually found it in a paper 2005, and when I saw it, I said, oh my God, this is what it is. So what is it? So if you look at the pressure gradients between the esophagus and the hernia and the stomach, and you look at the barrier function from the LES and diaphragm, it can explain why hernia is important in reflux. So we found, as Peter found before, that there are two types of LES pressure responses to breathing. One type of pressure response in the LES is the LES pressure increases. And I was surprised at that. I always thought LES pressure increase with inspiration is due to the diaphragm. But actually there is an intrinsic mechanism in the LES that with each inspiration pressure increases. And then we found other times, other patients with hernia, the LES pressure goes down when you take a deep breath. And it is those patients, the ones where the pressures decrease with inspiration, they reflux from the hernia into the distal esophagus. Every breath can lead to reflux under certain situations in hiatal hernia patients. So I'm sure my time is up. I'm sure I've taken more time than I was allotted. Anti-reflux barrier in 2021. We have better measurement techniques that allowed us to delineate structure and function of smooth muscle lower esophageal structure, sphincter structure and function of the diaphragm. I think flap valve is the same thing as a hiatus hernia. And it is related to this separation of the LES from the diaphragm. That's very relevant. These gradients, how it results in different pressure gradients across the, so this is Leonardo da Vinci saying that the function matches with anatomy. I'm not saying that. Finally, Engelfinger, what he was trying to look for, does the function matches with the anatomy? And this is, I hope I try to convince you that. The challenges in 2021, I believe, is not all heartburn in GERD. I think this is a misconception. We keep falling into that. Heartburn, we equate that with GERD. Not all heartburn is GERD or the spectrum of GERD. And what is the cause of low LES pressure in GERD, cause of hiatus hernia, and hiatal dysfunction in GERD? I think these are the challenges. Hopefully, I'm not retiring or going anywhere. I'll continue to work, but for the future generation. Thank you so much.
We're going to have you, Robbie, we're going to have you stay up here. We're going to ask John and Dan to come back up and open it up for questions, comments, suggestions. I did forget to say that Robbie and I are both big fans of cats. Robbie does experiments on his, I feed him.
Can't see anybody out there.
We do. It's hard to see, but yeah, they're over here.
I'll just shout out a question. Robbie, you show this beautiful work about
So I can tell you, obviously I don't have, I keep fighting with the NIH to give me a grant on that, but lo and behold, it hasn't resulted. I submitted that grant 5 times. So it hasn't happened yet. But I can tell you, the hernia, there are 2 very important things about hernia. One is the longitudinal muscles of the esophagus. Something is pulling the sphincter up into the chest. Second thing is the hiatus itself. My colleague showed there is something wrong with the muscle, the hiatal muscle. There is, loss of tissue, there is a lot of fat in there, connective tissue and all that. And we are looking into that actually, that what leads to that is maybe, this is a hypothesis yet, that the problems in the vertebral bodies, the hiatus originates from lumbar vertebra, L1, L2, L3. And this is where, if there is a problem on the origin of this muscle, or the bone where it's originating from, and degenerative changes in the lumbar spine are so common. So no wonder these symptoms of reflux and hernia are so common. So I believe, anyway, this is just a speculation, but we do have some data. The problem is in the lumbar spine.
Thank you so much. This was a very interesting presentation. I'm a surgeon from Michigan, so I just want to say something that we have been interested in doing research. Again, it's a rural hospital, nothing, no university hospital, but I think in terms of surgery, we equate crural closure to crural repair. So what we do is we think of the hiatus as a space, and we want to obliterate it. So we bring the anterior edge of the crus together. Now we don't see it, we're done. Versus crural repair, where we just get the whole hiatus, the whole width of the hiatus together, and recreate the crural sling. And I have a poster just with the picture. But I think all of us need to kind of pay attention. What are we trying to achieve? If we are trying to obliterate the space, okay, then we can go down the track, okay, what kind of mesh, what's the best mesh do we do? Mesh for small hernia. Or we can understand that what we're trying to get is, recreating the crural sling or doing a functional, closure. Again, the topic is a lot. I have a poster for it, but I'm interested to hear your thought.
Oh, we are.
Yeah.
So is that for me or for you?
I'll take that one. So yes, I think that the crural repair is incredibly important, and part of the problem is, like I presented in my talk, is you're dealing with tissue that's defective. And that's probably why they get the hiatal hernia in the first place. So if you just pull that back together, especially if it's under tension, just like any other hernia repair in the body, tension is going to kill that. So if you take a defective tissue and you put stitches in it, eventually the stitches are just going to pull out. So I do think that paying close attention to how you repair it, maybe we need to make more liberal use of relaxing incisions on the diaphragm so that we can get the tissue around the esophagus closed without tension, and then worry about areas that are going to be less critical to reflux. Keep the hernia from occurring there with a permanent mesh that you can't use up against the esophagus. And I do think that that's important, that you've got to pay attention to your repair and not just throw some stitches in there and close it up so that it's tight. I think you have to make that an art. Reg Bell actually does, sometimes will do almost a Mercedes-Benz where he'll close posteriorly, but then anteriorly over to the left, he'll put stitches above the diaphragm or above the esophagus to close it down to kind of recreate that teardrop shape of the hiatus. I think that's important.
So 2 things I want to say.
Okay, we've got time for one brief question. We're actually a little bit over here, so this gentleman's been waiting.
I'll talk quickly, thanks. Joe Speaker from the University of South Florida. Thank you, all 3 of you, for a wonderful set of talks, but my question was on the EHAS score and kind of this hypervigilance that we see. I definitely believe that because we have a lot of patients who, as you said, you fix and make beautiful anatomically, but still have issues. My question pertains to how do you action on that, though? What should we be doing to try and decrease that other than kind of positive reinforcement with patients? Are there strategies that we can use for that?
Yeah, so certainly, some of the things are focused more around the expectations. Like cognitive behavioral therapy, what you're really trying to do is have the patient understand that it's okay to have some belching. Or after surgery, it's okay to have a little gas bloat. Your hernia is fixed. What are your goals? And they talk about that. So I actually think, and we actually are starting a study in April, where we're going to preemptively put people through cognitive remediation before they actually get an intervention to see whether or not, in a randomized controlled fashion, that it does actually help outcomes. You don't want to catch them afterwards because then, you're kind of chasing things. They've already lost a lot of faith in the system and, they're angry. You want to catch them before, they get to that point because it does. It kind of reinforces itself. So I think the key is going to be to identify them early. And we usually get the EHAS scores when we're doing our motility studies. Kind of gives you a sense as to, where they are in terms of their disease state. And then if we identify that someone has a high EHAS score, then these are the people that, we will randomize to cognitive remediation therapy versus a sham kind of more of a reassurance kind of platform.
Thank you.
Preemptive strike. All right.
Yep.
Speaking of preemptive strikes, John is going to moderate the next section here,
With me.
which is on motor disorders. Sumit Mittal.
I saw Sumit.
So, thank you, speakers. Very engaging talks. These are beautiful illustrations. Beautiful illustrations.
Oh, thank you.
Well, I don't see my partner.
It's all you.
Is he coming?
There he is.
There he is. Good to see you. All right, well, we're going to move on to this next session here. And I think I saw Joel. Is Joel?
How do we get to the stairs, guys?
I can't see. It's so bright up here. So anyway, we're moving on to Motor Disorders 1. And this session is really going to focus a little bit more on the diagnostics. And for those of you who don't know Joel Richter's a long storied career in the esophagus. Currently is one of the editors of The Esophagus, the textbook. But many of you know that Joel has a fondness for barium esophagram, and in particular, the time barium swallow, or as I like to say, barium esophagram, with the tablet. And he's going to talk to us today about the value of that particular test. So I think they want us to stay up here. So.
All right. I love this. Well, wow, you're right. You can't see anybody. I feel like I'm at an evangelical revival, and this is a perfect setup to talk about something that is very personal to me in its evolution, the role of the time barium esophagram in the assessment of dysphagia. So a little historical perspective. This was not an original idea that I had. There was a gentleman by the name of Cohen who, after he did pneumatic dilatations in the 50s and 60s in the hospital, before he discharged them, he would do a emptying study of the esophagus, and was called the Cohen test. But when I was at the University of Alabama in the early 1990s with Bob Kohler, working with him, we both wanted to develop kind of an objective test to look at esophageal improvement in our achalasia patients, rather than relying on symptoms alone. And we originally considered doing a nuclear medicine study. At that time, a gentleman, DeMeester and Johnson, Larry Johnson, had a cornflake study that he did, or oatmeal study that he did, in the nuclear medicine lab. People at UAB in the nuclear medicine lab didn't want to have any of us working with them. And in real life, when we thought more about the barium, it was really true. When you look at a person with achalasia, most of them, what do they have in their esophagus? They have liquid. They don't have food. So in retrospect, it makes a lot of sense. Here was our first publication we had in the American Journal of Radiology. By that time, I was up at the Cleveland Clinic, also working with Mark Baker, and we published this study back in 1997. And this is actually one of the first groups outside the United States that got involved in this. Was actually a group from India, and this is one of their pictures that they had, which was a nice kind of colorful idea about the technique of the time barium esophagram. You use a medium weight barium. You have the patient drink the barium cup. Basically, it's like the size of a coffee cup, about 200 cc's, as rapidly as they can in 1 minute. And then you have them stay standing, and you repeat radiographic studies, just basically chest x-rays. And on our original platform, we did it at 1, 2, and 5 minutes. This is as simple as you can get, folks. And then the question was, how would you analyze it? Would you analyze it by the height? Would you analyze it by the weight? Would you analyze it by pixel count? We looked at a number of ways of doing it. It turns out the easiest and the most accurate, and nearly as accurate as more intensive pixel count, was to just look at the height from the esophagogastric junction to the top of the column. And guess what? We don't need a radiologist to do that. We can do that with our eyeballs. This is actually a study that Dr. Kostick did. He was a gentleman that was in my lab at Cleveland for a year, and then he joined Lars Lundell in Sweden. And they did this nice study in normals, because we do need to know what healthy normals do with their esophagus. And as you can see with the time barium esophagram, at 1 minute you can have some retention in some healthy normals, up to about 10 centimeters. But by 5 minutes, everything was emptied out of the esophagus. They also did some repetitive studies in their achalasia patients to show how tight the data is, and I'll show you that on the next slide. But you can see we were all beginning to narrow down that we're doing the time barium, what I initially called swallow, but as John said, is really an esophagram. And we narrowed down that the height was where we're going to get our most bang for the buck, not in the width. And this is from Kostick's study looking at the correlation between two studies done about 2 weeks apart in a group of achalasia patients, and you can see at 1 minute and at 5 minutes an excellent correlation of the measurements that we were getting. This is our current protocol at the University of South Florida. I've revised it some over the years. We now do only a 1 minute and a 5 minute, so we took out the 2 minute. And some years ago, I wanted to get back to something along the solid line, so at least the radiologists were very popular using a 13 millimeter tablet. So after we finish the 5 minute study, if there's any barium left in the esophagus, we have them drink some water, and then they swallow a 13 millimeter tablet, and that should be emptied by 5 minutes to be considered normal. What are we actually assessing with the time barium esophagram? In my simplistic thinking as a non-engineer earlier on, I thought we were looking at esophageal emptying. But we now know from nice work by a number of people, we're really looking at the compliance of the esophagogastric junction. How easy does that valve open to a weight that resembles the food bolus that we eat? And then the other important thing with the time barium esophagram, it is a beautiful anatomic study of the esophagus when it's obstructed. This is a study that we just finished about 2 years ago with Wojciech Blonsky at our experience now at the University of South Florida. My kids thought at one time I was in a witness protection agency because I was moving around so much over all these years, but now we're at the University of South Florida, and we were looking at the mathematical modeling of our achalasia patients, and as you can see here, using ROC analysis, barium height of 2 centimeters at 5 minutes had 85% sensitivity and 86% specificity. Remember that number of 2 centimeters. Here's EndoFlip that John and his group has popularized. Another way of looking at this compliance, probably a little bit more mechanically accurate and certainly more colorful than the black and white time barium esophagram. But lo and behold, another study. Now we're over across the pond in the Netherlands, taking the group of patients from the big multi-center study that they did comparing pneumatic dilatation and Heller myotomy. And now we're comparing patients both that had had EndoFlip and it had the time barium esophagram. And in the light gray is the ones who aren't doing well, who have impaired distensibility, and the time barium esophagram is abnormal. And in the darker gray, that 2 centimeter mark in the Netherlands was the same thing as we had for the patients who were doing well with normal distensibility. So that's your important cutoff number. It also, as I said, gives you beautiful pictures that are easy to show to the patient. We do this all the time in the clinic. Here's a type 1A achalasia on the left with the L-shaped elbow. Here's a type 3A achalasia in the middle. Here's even a nice picture of an epiphrenic diverticulum. So what are the clinical applications of the time-barium esophagram that I think all of us should be thinking about in our esophageal centers? Certainly it's very important in achalasia patients, and actually we do it in everybody. It supports the HRM diagnosis of achalasia, and as Chicago 4 has said, it now helps in resolving the up to 20% of patients with inconclusive HRM diagnoses of achalasia when the IRP is less than 15 millimeters of mercury. And it's also, as I'll show in a moment, a good short and long-term predictor of success regardless of what treatment you're doing, as long as it's not Botox. We also use it in esophageal gastric junction outflow obstruction, and we also now routinely use it in our patients with non-achalasia dysphagia when it's not obvious EOE or difficult to manage endoscopic stricture. Here's the accuracy of the time-barium swallow with a 13 millimeter tablet now in this same group of patients. And when you combine those two, the barium emptying and the tablet emptying in 107 unselected patients with achalasia, 100% of the time they had one or both of those abnormalities if you had achalasia. 60% in outflow obstruction, 40% in the nonspecific dysphagia cases. And here's the old time-barium esophagram that we were originally doing at 1, 2, and 5 minutes. Again, beautiful anatomy. And then what you would like to see in these patients that would give you confidence that you've had good results with whatever your treatment is good emptying of the esophagus. Now, how much is good has taken us a while to kind of figure out. And when Mike Vasey and I published our first article about outcome, we basically had two groups of patients. All of these were treated with pneumatic dilatation. We had a group of patients, the concordant group, that's time-barium swallow had normalized, as I showed you in the previous x-ray, and also who are asymptomatic. That was a concordant group. And then we had another group that symptoms were great, but they still had a lot of barium. They said, Dr. Richter, you seem to be a nice guy, but you told me there's a 1 or 2% perforation rate. I'll just wait to see what happens. And lo and behold, when we followed all of them up at about a 5-year, the ones who were concordant were doing well. The ones who weren't were generally back to see us within a year. Here's a study with the group, Lars Lundell's group in Sweden, same type of finding. When there was a marked amount of retention on the barium study, after this case of Heller myotomy, about a year later, the patients were back, whereas there was 50% improvement, they were not. This is from the New England Journal article looking at predictors of recurrence, particularly after pneumatic dilatation. And you can see post-treatment, 3-month barium stasis greater than 10 centimeters was a high predictor of needing more treatment. We're still wrestling with what should be the right outcome in this area for a long-term predictor. Some have suggested, this is from the Netherlands group, maybe a cutoff of a column 5 centimeters or less at 5 centimeters. In this study, with an average follow-up of 17 years and 25 patients with recurrent symptoms, you can see an elevated LES was worthless. 22 of these patients had retained barium on their study, and you can see the high sensitivity and specificity of the esophageal stasis. So when there is stasis, you need to follow those patients more closely. We've continued to look at this more recently in this article because of what we observe. Some of these people have very high columns. They'll have columns all the way up to their clavicle. And so what do you do when they're coming back and they're asymptomatic, but they still have maybe 6 centimeters of retention or 7 centimeters of retention? And it turns out those patients are actually going to do pretty well. Here's 81 patients, average follow-up of 2 years. You can see both types of treatments. We actually think that the percent emptying might be a better marker than the 5 centimeters at 5 minutes. It may be almost too good, though, because of the accuracy data that we're seeing at the bottom. as compared to the 5 centimeter retention. The way I would use it for you in clinical practice, if you don't have a time barium swallow beforehand, use the 5 centimeter cutoff. You like it that or less. If you have the comparison, then as long as you get a decrease, and the greater the decrease, the better they're going to do. Well, what about this in esophagogastric junction outflow obstruction? It is essential to use the time barium esophagram or the endoflip because we now know that this is not a conclusive diagnosis and requires supportive evidence of obstruction. And here's one of our patients, got it referred into a surgeon because they were going to do anti-reflux surgery, and the manometry came back as an achalasia-like syndrome. They didn't know what to do. We did our study, found outflow obstruction, but we did the time barium esophagram right after that. And I hope you can see on the left at 1 minute that 2/3 of the stomach is in the chest, and on the right, the tablet holding up. Surgeon did the operation, did great. Now here's a functional case of outflow obstruction, same values. This guy was kind of interesting. Not only did he have dysphagia, but he had some regurgitation. He had more of a bird's beaking that you see on the left, again with the 1 minute film. Notice how great you can see the anatomy and then the pill hanging up on the right. And basically a study that Steve Clayton and I did. The pattern that seems to be most interesting in time barium esophagram with outflow obstruction is retention at 1 minute, but I'm a little cautious of that because that can overlap with normals in the pill hanging up. But here's a study we did with pneumatic dilatation in about 35 patients, and you can see that about 75% were doing well after 1 or 2 pneumatic dilatations. I have some out about 6 or 7 years, and you can see we had striking improvement in 1 minute emptying, going from 11 centimeters to 0 median, and pill retention from 76 to 40%. And what about for the non-achalasia outflow obstruction groups? Here's a patient coming in with dysphagia obstructing lap band. This picture is good as any radiologist can obtain, and I can read it very easily. And here's an interesting gentleman with cervical dysphagia. And I got a call by my radiology tech saying, Dr. Richter, the pill's still up in the neck. And you can see the pill was still up in the neck at 30 minutes, replicating the patient's symptoms, gradually dissolving. And that was because they had a cervical web and easily to diagnose. So should you be using it in your community practice? My answer is absolutely. Everyone can do it. It's cheap. It's easy. It's reliable, and it's easy to start. It's not expensive. It doesn't require another endoscopy. And at the University of South Florida, now we've got a boutique practice of complicated cases, but our patients come in, we've screened them for their dysphagia, and all these patients, they start out with a high-resolution manometry in our lab, go downstairs to radiology, have the time barium esophagram done, then we see them. 40 to 50%, we've taken care of everything other than their management plan just with that information. So, as Mike Vasey recently wrote, I want to give Mike credit for this, old is not bad, John, and sometimes better than new. Thank you very much.
Just sit here.
Yeah, be easy.
That was a great talk, Dr. Richter, and I'm going to have the pleasure of introducing John Lipham. Everybody knows him. He's the past president, as just pointed out 5 times, and a great lover of cats, I believe. So, welcome, John.
All right. Well, welcome everybody to the 3rd AFS, I guess 2nd in person, but very glad that you could be with us. Waiting for the slides to queue up. There we go. So, you know, I was asked to talk about video esophagram. And the question that was posed to me, and the question that I've been asked quite a bit, was, well, can it replace manometry? So I only got 10 minutes, but I'm pretty confident in those 10 minutes I'm going to probably piss off about 93% of the people in the crowd, and the other 7% I will convince you of the utility of video esophagram. So, without further ado, because I only have 10 minutes, first the disclosures. These are probably the most important part of the entire talk. I am a consultant for Ethicon Thorax, which has absolutely nothing to do with this talk. I think what's most important to understand, though, is I come from a different place. I come from USC. I come from Dr. DeMeester. So I'm really about as inbred as they come in regards to the values at USC. And I can tell you, growing up at USC, manometrically, it was the center of the universe. Everything really did revolve around manometry. I did feel like one of the family, though. This is one of the DeMeester events at the house. You can see the manometry machine right there that Dr. D carried around with him at all times. If you look closely in the back of this picture here, you'll see a second Tom DeMeester. That's how he was able to get as much done in his career as he did. There were really two of them. Now, if I recall correctly, Steve was at that party also. Here's Steve, who also walked around with his manometry catheter. And then our crazy Uncle Jeff was there also. So all of us were all happy in the family doing manometry. And so I got a lot of experience with manometry over the years. And so I can tell you right now, and we'll shorten this talk, video esophagram is not going to replace manometry. It isn't. It does not replace the utility of manometry. But the better question, and what the question should be for this talk, is can video esophagram serve as a screening test to determine who needs manometry? Because I can tell you right now, the dogma, the traditional teaching, has been that prior to any anti-reflux procedure, everyone has to have manometry. That's how we were all taught. If you're going to go to the OR for a Nissen or a Toupee or a Lynx, you've got to have manometry. And so the other title for this talk in my mind was Dogma versus Science, or Challenging the Status Quo, because I will ask you, where is the science to suggest that every single person that goes to the OR has to have manometry? Somehow I think this predicts, or this implies, that manometry somehow is going to predict the patient that's going to have post-op dysphagia. Because us as surgeons, that's our big fear, right? We're going to do a procedure on this patient, and they're going to develop really bad dysphagia. So somehow manometry keeps us out of trouble. Well, I'm not so sure that that data really exists. There's a lot of data to suggest that it doesn't exist. Here's one such publication from a number of years ago that looked at 74 patients. This is from Pellegrini's group, where they did manometry and impedance and 24-hour pH testing out of the patients. They all got a laparoscopic Nissen fundoplication, and they looked retrospectively at whether or not there was any characteristics on that manometry that would have predicted the problem patients, the patients with post-op dysphagia. And at the end of the day, what they found was manometry didn't predict who was going to have problems post-op. The only thing, and this is consistent throughout the literature, the only thing that seems to predict post-op dysphagia after anti-reflux surgery is pre-op dysphagia. And so I decided to phone a friend, so I called Steve and I asked Steve, tell me what your thoughts are on this whole manometry versus no manometry before we do anti-reflux surgery. And so Steve actually published an article on this, and it's a little bit misleading title, and I'll read it for you. It's Preoperative High-Resolution Manometry Criteria are associated with dysphagia after Nissen fundoplication. Like I said, it's a little bit misleading because what it was a retrospective review of 94 patients. They did some very fancy statistical analysis called bootstrapping to get it up to almost 3,000 patients. What's cool about this publication is they broke it out into patients that preoperatively had dysphagia and those that did not, and analyzed those groups separately. Well, I can tell you in this publication what they found was that in the patients that did not have any pre-op dysphagia, manometry did not predict anything about who was going to struggle with dysphagia. Now, one thing that was cool about this publication, though, is in that group that had pre-op dysphagia, they did find a significant association in certain values of manometry that would predict who the dysphagia would resolve. But as a whole, again, pre-op or manometry did not predict who was going to have post-op dysphagia. So this idea of tailoring the fundoplication, like I said, I'm not sure exactly where it comes from. And I think, to me anyway, it's founded in a little bit of dogma. This right here was a randomized controlled trial that looked at or they did preoperative manometry on 127 patients. They broke it down into either effective manometry or ineffective manometry. They then randomized patients, irrespective of their manometric findings, to either getting a Nissen or Toupet, and wanted to see what the dysphagia rates were. Well, 1 year after their Nissen or their Toupet, what they found was that there was really no difference in reflux control, but Nissen as a whole did have a higher rate of mild dysphagia as well as chest pain. Now, what was interesting was when they looked at the patients that had ineffective versus effective manometry, there was no difference, again, in post-op dysphagia. And so their conclusion was there's no reason to tailor the fundoplication based on manometry. And so before you drink the high-resolution manometry Kool-Aid, let me go to sort of what most would consider a more dysphagiogenic procedure, and that's LINX. And we looked at the LINX group to see if manometry would predict who would struggle with LINX postoperatively. Now, this isn't published yet, but it is written up, and Brian, I think, has finally got it accepted. But this was a multi-center retrospective matched cohort study where we looked at 105 patients that had ineffective esophageal motility and compared that to normal individuals. What we found was that, again, the manometry didn't predict anything, not even with LINX. New onset dysphagia was the same between those two groups, whether you had good motility or bad motility. Resolution of pre-op dysphagia, we looked at that, and again, no significant difference between those that had ineffective manometry versus effective manometry, and the symptom scores were the same. So again, it didn't help us predict that problem child after LINX. So for me, what we need to do here, and what the beauty of manometry is really to rule out severe motility disorders. Achalasia, scleroderma-like esophagus, or maybe even severe ineffective esophageal motility. So we went out or set down the pathway of asking the question, can barium swallow help, as I said before, screen the patients to see who would need manometry? So not every single patient and their brother had to get manometry before having surgery. So we looked at a group of patients at USC. For a while there, we were doing video esophograms and manometry on every single patient that walked through the door, whether they had reflux or not. So it amounted to about 418 patients that had both video esophagram by a dedicated radiologist by a set protocol. And that is the caveat here to this publication. This isn't your standard, we'll send them over to radiology for an upper GI. It's a set protocol with a dedicated radiologist. All 418 patients also had high-resolution manometry, and we looked at whether or not, we asked the simple question, if the video esophagram was normal, did the manometry pick up anything that was going to change our mind or approach to treating that disease? At the end of the day, what we found, the answer to that question was it didn't. If the video esophagram was normal, manometry didn't ever pick up anything that would have changed our mind. Again, meaning achalasia, scleroderma, or severe ineffective esophageal motility. I'm kind of running out of time here, but just a couple of key points here in regards to the protocol we used here. One thing that was super important was that the upright swallows did not predict anything when it came to the manometric findings. The key part of this whole test, this dedicated protocol, was when patients were in the prone oblique position. There is where we saw a correlation. If that was normal, manometric findings, again, did not pick up anything. This was recently followed up by a Japanese study. It's not quite in print yet. It is in press. That did a very similar study. They looked at a solid and liquid barium protocol that they developed. They also added a special classification system, what they called obstruction level, meaning the degree of passage through the esophagus or lack thereof. And at the end of the day, what they found was that, again, a dedicated protocol done by a dedicated radiologist using solid and liquid barium could predict those that actually needed manometry. And so the summary, suggestion, and then I'll open it up and welcome your thoughts, is follow the science here. You know, the yield on routine manometry is extremely low. It doesn't seem to help tailor the operation, so we've got to question whether every single patient
needs manometry before having anti-reflux surgery. Again, the exceptions here, achalasia, severe IEM, and scleroderma-like esophagus. So I would suggest partnering with your radiologist, adopting one of the protocols, either ours or someone else's, to screen those patients that potentially actually need manometry before anti-reflux surgery. So with that being said, I will yield the podium and turn it over, I think, to Dusty.
Great job, John.
Thanks. Are we staying up here?
Yeah. Great job, John. Now I guess we will move from something old to something new and bring up Dr. Dustin Carlson, who is one of our partners at Northwestern. I think, John, we may be as inbred as USC at Northwestern. You know, Peter to me, and now Dustin has taken over the esophageal motility lab at Northwestern and is probably the foremost authority on FLIP currently in the world, I would say. So without further ado, Dustin Carlson.
All right, well, first off, thank you very much, John. Very kind words, I appreciate them. And thank you very much to all of you. Also thank you to the American Foregut Society and the organizing committee for having me today. And I'm excited to share with you some of our approaches and data about FLIP panometry, and certainly recognizing some updates we've had recently. This was perhaps one of our COVID hobbits, if you will. And finally, I just certainly want to recognize how great it is to be here in person and how great it is to see so many of you. And so, yeah, I won't get too nostalgic, hopefully, here. But here we go, a couple disclosures. Anyway, so with FLIP, this is a device that is placed in the esophagus at the time of a sedated endoscopy or during sedated surgery, and uses an impedance ponimetry technology to measure luminal dimensions along the length of the esophagus as the balloon is filled with fluid, and also pairs that with simultaneous pressure sensors, using a pressure sensor inside the balloon. And so looking at that relationship between esophageal caliber and pressure gives us a measure of distensibility. And this can be measured across the esophagogastric junction, at the esophageal body, measuring distensibility in both of those, and also can assess the contractile response to distension. Again, here showing this example. This is the real-time endoscopic display that looks at this pattern of repetitive antegrade contractions in a healthy asymptomatic volunteer. This is representing repetitive secondary peristalsis as this balloon distends the esophagus. Using this together, looking at distensibility, looking at this contractile response to distension, we can evaluate esophageal motility in real time at the time of sedated endoscopy. And so in a short 10 minutes, we'll try to focus this on using FLIP panometry to assess esophageal motility. And so in a brief outline here, we'll start just with the study protocol, which is important, then move into the contractile response to distension, which is secondary peristalsis, finally EGJ distensibility, and then bringing it together to assess esophageal motility and some clinical application. So first off, who should this be applied to? And really using similar criteria as to what the Chicago classification uses when evaluating for primary motor disorders. So I think there's a role here in that primary evaluation, that index endoscopy that's being performed on a patient presenting with dysphagia or chest pain. And if the EGD there detects a mechanical obstruction, severe esophagitis, large hernia, that's not a scenario where you necessarily need a primary motor disorder evaluation. Certainly there is a role for motility testing there, but that's a little bit outside the scheme of the Chicago classification and what I'll describe here. But also with FLIP here, I think there's a very important complementary component using FLIP, particularly in patients who may have some of these equivocal or inconclusive initial diagnoses. And the prime example here is that EGJ outflow obstruction patient based on manometry. And in either of those scenarios, if an endoscopy is being performed, FLIP can be paired with that endoscopy to help evaluate esophageal motility. In some scenarios, that may help direct endoscopic therapies, and in other scenarios, that may actually direct towards subsequent evaluation. So just to kind of review the test protocol here, one thing to keep in mind is that as I talk about evaluating motility with FLIP panometry, this does imply use of the 16-centimeter FLIP balloon as opposed to the 8-centimeter balloon. And this is done during a standardized filling protocol. The balloon is positioned in the esophagus, it's positioned across the esophagogastric junction, and that can be seen really by a waist on the real-time display. And that positioning is maintained throughout the study. The study is then performed in the stepwise filling volume, and interpretation is volume dependent. Certain things to look at. One is we've defined the contractile response, and some of the contractile response patterns I'll describe in a moment really are based on looking at the global impression of what happens at the 50, 60, and 70 ml fill volume. Those of you who've used FLIP and may have seen some of our previous data, we used to focus a little bit more and apply some of the lower fill volumes. One of the things we definitely have come to recognize more recently is that these lower fill volumes, when the balloon is incompletely filled, are subject to some types of artifacts. Something called the dry catheter artifact can disrupt and maybe mislead a little bit of the EGJ opening. It's also prone to some artifact related to movement and respiration that can manifest like contractility, whereas focusing on the higher fill volumes does provide a little bit more of a reliable and valid assessment. Additionally, we look at the EGJ using two separate metrics. The EGJ distensibility index is really best identified using the 60 ml fill volume. And lastly, we look at the max EGJ diameter, the greatest diameter that's achieved across the EGJ between the 60 and 70 ml fill volumes. And all of these can be applied together to evaluate motility. So first off, talking about the contractile response patterns. And we've looked at a series of patterns here that we see commonly, and these really do reflect a bit of a pathologic transition from normal, which we see in about 90% of asymptomatic volunteers and many patients with normal peristalsis on manometry, to abnormal, an absent contractile response, which we commonly see in non-spastic achalasia and patients with a scleroderma-like esophageal dysmotility. Now, with the normal contractile response, this rack pattern, this is something that we further define to be a specific pattern of normality using what we've called the rack rule of sixes. So you can think about having more than 6 antegrade contractions that are at least more than 6 centimeters in length, and the rate is important here. And the rate is just this rate of kind of consistent rapidity, and typically that is right around 6 antegrade contractions per minute. Now there's another pattern, and really it's a kind of a series of patterns that we see that are abnormal. And this is something we've defined as kind of the spastic reactive pattern. We see these commonly in patients with spastic motor disorders, type 3 achalasia in particular. But we get up through the reactive feature in there because we sometimes do see these features in patients that have hiatal hernia and some other findings that may suggest that there is a reactive component here. And these are these sustained occluding contractions of the esophageal body. Sometimes contraction can involve the lower esophageal sphincter. And this repetitive retrograde contraction pattern, the RRC pattern, which we've actually kind of further refined over the years. And really now we're including some rate criteria, recognizing that there is a rapid rate that really is associated with the pathologic finding of RRCs. And we looked at this pattern across a large cohort of patients. These are all patients who were eligible for Chicago classification assignment. So having 706 patients, we defined primary motility, primary peristalsis on manometry, and we looked at this contractile response pattern, and we could see that with most patients who had a normal or even borderline contractile response, they generally had normal primary peristalsis as well, and yet as that progressed, an absent contractile response very infrequently had normal primary peristalsis, and vice versa, and kind of conversely, as patients went from this normal to an absent contractile response, had a much, much higher level of having failed and ineffective swallows, where there was a little bit more of some kind of heterogeneity among the spastic reactive pattern. And an important feature here as well is that within this normal contractile response, people who had the rack rule of 6 pattern, nobody with achalasia in this large cohort had that pattern. And even kind of moving on to this borderline contractile response that involved antegrade contractions but without spastic reactive features, this was very few, a couple percent of this population that had achalasia in here. So kind of using this and looking at this as a probability of normal or abnormal peristalsis. Next, I'll look at EGJ opening. Here we can look at the distensibility index at the 60 ml fill volume or at the 60 to 70 ml fill volume to look at the max EGJ diameter. And this is measured at times based on the contractility. With antegrade contractions, we look at the peaks of opening. When there's not contractility, this is a little more of a stable measure across the portion of the study. And we can define this again using 2 measures. So looking at both the EGJ DI as well as the max EGJ diameter, and putting these together, looking at when these are both distinctly abnormal, we can define this as a reduced EGJ opening, and when it's distinctly normal, call this a normal EGJ opening. That does leave a middle ground here, kind of so this gray area where there's a little less certainty, and this is what we define as a borderline EGJ opening pattern. And when we looked at this and using another large portion of patients who had either conclusive EGJ outflow obstructive disorders based on the Chicago classification, so achalasia type 1, 2, and 3, but also EGJ outflow obstruction that was also defined by abnormal time-bearing esophagram, we see that the vast majority of these patients will have reduced EGJ opening, a smaller portion having borderline, and very few having normal EGJ opening. On the other side, looking at patients who had normal EGJ outflow by the Chicago classification, most of these patients had normal EGJ opening, fewer with reduced EGJ opening. And so I think a couple conclusions here. One is that when EGJ opening is normal, this carries a very high negative predictive value for EGJ outflow obstruction. And in particular, when applying this to those inconclusive manometric diagnoses, if you have normal EGG opening on flip, you can very effectively rule out this as a clinically conclusive or relevant disorder. But the other side here is that there's this group here that had perhaps normal outflow manometry, but did have reduced EGG opening on flip. And here we see that there are processes other than impaired LES relaxation that may be associated with reduced EGJ distensibility, and an abnormal contractile response in response to distension that occurs in these normal patients with normal LES relaxation, I think is a large component of this. And this is something that we actually commonly see in patients who have small hiatal hernias. And that brings up the point that there are some of these differences here. And these are innate differences between the way the esophagus is stimulated with these two tests. Remembering that with manometry, you're looking at swallows, primary peristalsis. With flip, you're looking at the esophageal response to distension, secondary peristalsis. But when we compared these, we looked at another 329 patients who completed manometry, completed flip, completed time-bearing esophagram as well. And when we looked at this, IRP actually performed pretty well to predict retention on time-bearing esophagram. Flip metrics with EGG opening performed a little bit better. And perhaps more importantly, as we looked at some of these discrepant patients, those who had abnormal IRP and manometry, but normal EGG opening on flip, the majority of those also had normal esophagams. Conversely, when there was abnormal flip but normal IRP, those also had abnormal TBE. And so altogether, the agreement with TBE was 78% of patients with flip, as opposed to only about a quarter of those patients who had manometry. So again, this kind of showing how time-bearing esophagram, like Dr. Richter suggested, probably measuring some compliance at the EGJ, fits very well with a test that measures compliance at the EGJ. And so to conclude, we'll wrap up with this thing that we can put these pieces together, looking at the probability for EGJ opening with the probability of normal peristalsis to define an esophageal motility disorder. In a paper that was recently accepted for publication, we define these disorders recognizing that with this normal pattern, major motor disorders are very frequently ruled out. This is a scenario that you may not need to proceed with manometry and instead can focus treatment on GERD or functional disorders. This weak pattern, again, achalasia is likely ruled out. Assessment with primary peristalsis with manometry may be valid, but again, achalasia very unlikely with normal EGJ opening. Other patterns that may be associated with obstruction, if there is normal contractile responses, this is also going to be not typical for achalasia, and so may instead reflect a mechanical obstruction. And recognizing that flip is performed with endoscopy, this is a scenario where we could do a second look endoscopy, consider doing a dilation at the time of that same encounter. Moving on, this pattern with obstruction, but with abnormal contractile responses, abnormal secondary peristalsis, is typically going to be achalasia, and more commonly non-spastic achalasia. In a scenario where there's an abnormal time-bearing esophagram, manometry may actually not be necessary. If there is discordance, though, if there's a hiatal hernia, certainly this is a situation where pursuing manometry to cement the diagnosis is going to be necessary. And then finally, there are some of these scenarios where it's a gray zone from the flip, an inconclusive flip manometry, or with a spastic reactive pattern, where those findings during an endoscopy tells you should proceed and do manometry to complete the characterization of the esophageal motility. And so that'll conclude. And just recognize that you can assess esophageal motility during endoscopy with flip manometry. This can have some roles in either primary or complementary evaluation. Again, the power of a normal flip manometry is that it very effectively can rule out major motor disorders, especially achalasia. Achalasia, on the other hand, will very frequently have and almost always have an abnormal flip manometry, though continue to recognize that not every abnormal flip manometry is achalasia. And in some of those scenarios and applying some of those concepts, this can be very useful to help sort out the inconclusive manometric EGG outflow obstructions. But in other scenarios, certainly abnormal flip, does need to be used in a complementary manner with manometry and perhaps barium esophagram as well. And all of this is something that can help complement the diagnostic impression at the time of endoscopy, either help direct endoscopic therapy or help move on to a more definitive diagnosis. So thank you, and I'll welcome questions during our discussion.
Guess we'll.
Any audience questions?
Questions?
I can't see anything.
I know, the lights are really bright.
So I guess I'll ask a question. No, okay, good. Got me off the hook.
Oh, Steve, that person.
Thank you guys for the great talks. Very interesting. Couple questions for Joel. You brought up the issue of EGJ outflow obstruction, then you proceeded to show us a very nice large perisophageal hernia. We found that a lot of large perisophageal hernias are associated with EGJ outflow obstruction. And release or repair the paraesophageal hernia solves the problem. So were you suggesting that that patient needed a myotomy? And I think Christy can talk to us, but she's been straightening the paraesophageal hernias out and doing flip, and has shown that these patients really don't have, it's an anatomic problem, not a muscular problem of the LES in these people.
Well, we would call that a type 3 hernia that I showed you. But no, that wasn't, the comment was, in reality, our experience has been that the majority of people with an HRM showing esophageal gastric outflow obstruction, even when we define an abnormal time barium esophagram like I showed you on that first case, that went to surgery and had an anti-reflux operation, hernia was reduced, anti-reflux, is that the outflow obstruction is not a functional abnormality. It's related to large hiatal hernias, peptic strictures, EOE, and then a sundry of things, and rarely, particularly if they have a lot of weight loss, you need to think about cancer.
Yeah, that's good. Just so we're on the same page, that is a paraesophageal hernia. Most paraesophageal hernias are type 3s, so that's usually what we're talking about when we're talking about these big paraesophageals. Yeah. And then I just wanted to address John Lipham a little bit. He knew it was.
Bring it on.
So, John, getting back to this, just what I said about paraesophageal hernias, one of the things that drives me insane is that most of the radiologists, when they do an upper GI study, just say large hiatal hernia. They won't even specify whether it's a sliding or a paraesophageal, which then leads to an insurance denial when I submit a claim for paraesophageal hernia repair, because they say there's no objective evidence that the patient has a paraesophageal hernia. So the point is, I can't even get a radiologist that can say the difference between a sliding and a paraesophageal hernia. Do you really think the average community radiologist is going to follow the USC protocol and give us reliable information on prone oblique views in a barium swallow? I just don't think that's reality.
Yeah, no,
So the danger is that we're going to promote a message that less is more in terms of preoperative evaluation. I just want to make a point to everybody. Almost nobody needs a fundoplication. A fundoplication is great for people with objective confirmed reflux disease and does a great job, but they don't need it. So if you don't need something, there's alternatives, which means we have to select patients carefully for the surgery. The better we select them, and you know this, the better we select patients, the better the results. When you willy-nilly take patients with symptoms of heartburn to the OR, we know the results are not as good as if you confirm those symptoms are related to reflux by pH testing and so forth. So the more we shave down on our assessment, the higher the risk that we're going to end up with dissatisfied patients.
So what do you think about that, John?
We want.
What do you think?
So a couple of things here. First and foremost, I don't disagree with the radiologist's comment at all. And so what I usually will tell everyone that asks about doing barium as a screening tool is that one of the caveats is not only do you have to have a radiologist that's agreeable to do it, but you need to look at all the studies yourself. Just like I do, just like Reg Bell does, just like anybody that's adopted a video esophagram as a screening tool. If you rely solely on your radiologist, no, the wheels will come off completely. I don't disagree with having more information, more data, but manometry hasn't given us that. If you're going to sit here and tell me that manometry is going to predict who the problem child is with post-op dysphagia, I disagree. It hasn't done that. Now, it can rule out achalasia, and it can rule out scleroderma like esophagus and severe IEM, but again, our data would suggest that a well-done video esophagram that you've reviewed can do the same.
All right, I'm going to get in between the two brothers here.
Wait, can I just, I want to add one thing.
We have people who've been waiting for...
I know, but it's
But you're not
That
important.
was a lecture.
No, I'm not asking another question. I want to add on. John, I want to point out, thank you for showing our really obscure bootstrap data. But I want to point out the reason that we bootstrapped is because we were digging and digging and digging to find a utility for the manometry to predict post-op dysphagia, and we couldn't.
All right,
So I
we didn't
think
say
your
we would
point is
let the
well taken.
sister in.
But so you're agreeing with me.
We're going to go to
Now
the next
you're
question.
getting in the middle of the.
All right.
So thank you very much for the presence, everybody there. I want to go to the flip for anybody in the audience or moderators up there. Any role, this is Jose Espinel from Carrollton, Georgia. Anybody has experience in, or there's any role for intraoperative flip technology to tailor or foregut surgeries like crural repair, fundoplications, or links? And if so, there's any protocol out there? And I know there's some, but I want to hear about the practical experience.
All right, I'll take on that, at least in regards to Heller myotomy, or POEM for that matter. I think EndoFlip has become sort of, in my mind, standard of care. What we have discovered is our beautiful myotomy isn't always enough. Frequently, we blow up the EndoFlip and find that distensibility index hasn't changed. We go back, sometimes it's just little scarred fibers within that area of submucosa that we break up and the DI goes now up to 3, 4, 5, or that we haven't extended it enough proximally or distally. So I've gotten to the point where I won't do a myotomy or POEM or anything without EndoFlip. Now, in regards to using it for anti-reflux, there may be a utility. I think many centers are collecting that data right now to see if it helps us determine how tight the hiatus should be closed, but I don't think we have that data yet.
Exactly. I don't think there is data for that yet. I'm just not convinced yet for that POEM either. Sorry, not for POEM, but for Heller. For Heller either, but I think that's where the utility is going to be for cutting the muscle, that have you cut enough muscle. Now, whether how tight you're going to put it, I think there's some people working on it. The only time I use an EndoFlip is that if there is a very strong evidence of, let's say, paraesophageal hernia with EGJOO and on barium swallow, there is delay, the patient complains of dysphagia, then after I reduce the hernia, I may do an EndoFlip to make sure there is good distensibility to decide whether I'm going to do myotomy, do I need to add in myotomy or do I just need to do a wrap? So that's the only time that I have really found a utility, and that's very few people, not to tailor my wrap or cruise closure.
Any experience with links and flip? I know, John?
Yeah, I mean, we tried to see if it would help us with sizing of links, and it didn't correlate at all. I think if there's any utility to EndoFlip, it may be in sizing or helping us gauge the crural closure, but it didn't help us with sizing of the links. We did a series of 20 or 30 patients. And
thank you.
Okay. Next question.
Yeah, hi, Reg Bell. So, John, you've run across this too. Not uncommon in a LINX patient gets a post-op swallow and the pill hangs up. Now, rarely do they image for 5 minutes, like Joel indicated. But my feeling is sometimes that's normal. It's a normal finding post-LINX. But I like your expertise on that also because it's a very common question that comes up amongst LINX users.
yeah, I know there's some studies that show that barium tablet hanging up in a non-operated patient, non-LINX, means something, but at least from what I've seen, post-LINX it doesn't, because it does frequently hang up, either because of the LINX or the angulation from repair of the hernia, I'm not sure. But pre-surgery, I think it's helpful, the tablet. Post, I'm not so sure.
Joel, any comments? Because I know you've...
You know, the experience that we have with the links, and we're doing it, I'm invariably, when I do the time barium esophagram, they have dysphagia. So, and I have to say, it's not always that it holds up at the link, so I can't make a real comment about it.
Thanks.
Hi. Dusty, thank you so much for such a beautiful talk summarizing really the role of EndoFlip and the strength of that technology. My question to you, and maybe it really is applicable to everybody that's on the podium, has to do with an algorithm for us in terms of what we should be doing as a gastroenterologist when patients present with dysphagia. Meaning, should we be prepared at the time that we invariably are taking them for an upper endoscopy that if we don't see obvious obstruction or, God forbid, a cancer or whatnot, to do EndoFlip at that point in time? And should this become sort of a standard of care as opposed to potentially doing it, maybe not having any answer at the time of the endoscopy? And I'm not saying you could still get your biopsies to rule out EOE and all these things, but from a standpoint of saving, dollars, would it be most efficacious to write that in there, consent the patient before? If you don't find something, do the upper, maybe do the biopsies, and do the endo flip at that point in time?
Yeah, thanks so much for that question, Felice. And yeah, I think that there is a definite, argument that can be made to do that. And I think, like you said, is a great point. You have to have the endo flip available, and you have to be prepared to use it. But I think you also have to have some of the restraint to recognize that if you identify another cause, a large hernia, esophagitis, I mean, you may not need it, and you can cancel it and leave it aside. But yet, at the same time, you're absolutely right that those are scenarios where that flip during that first endoscopy can very much help direct where you're going with that patient. And are you really going to focus on, is this a motility disorder? Do you need further evaluation for motility? Or can you certainly just rule out that there's going to be an abnormality on manometry? And yeah, from a patient convenience, from a patient acceptability, certainly from a just access of care and using manometry and when to use it appropriately, I think flip can really help direct towards all of those answers. So yeah, I think that's the direction that this is going, and I think there's certainly emerging data that will support that approach. So thank you.
Thank you.
Yeah, I mean, I'm horribly conflicted when it comes to flip. I get paid every time you buy a machine, so that's my conflict. $75 goes right into my checking account every time you buy one, so I need to let that out. But I feel strongly about it. But my biggest conflict, I've been working on that technology and that kind of approach for 20 years. And so I mean, my biggest conflict is that I've been working on this, and of course I want to see it work. I do think the fact that it's coupled with endoscopy is the one part that maybe we don't talk enough about. When you're scoping someone, you're in there and you're making those decisions, you look at the flip, and it's just like when John said, in the OR, I mean, that's what we do in the endoscopy suite. If it looks obstructed, I'll look back at it. Did I miss a stricture? And there have been times where I've gone back, I missed strictures. And I'll tell you, manometry, we saw a nice picture of Steve with the catheter down. I've had 8 manometries, and Dusty almost killed me about 6 months ago with a combined manometry flip.
True story.
They're difficult. It's not a nice procedure. So, if you can avoid that for some people, I mean, I think that's also a plus. So, should everyone who gets an upper endoscopy with dysphagia get a flip? I don't know the answer to that. I mean, I don't know how cost effective it is. But I'll tell you, using that index endoscopy to get as much information as you can to help that patient is really helpful. And you can direct therapy right then and there.
I mean, I would actually say it would seem to me so obvious that it's cost effective. And beyond that, it would be patient-centered and practicing, in some way, really personalized medicine for these patients. So I can't imagine if you actually were looking at it that anyone would argue that. I also think if, let's say, practitioners did not feel comfortable even reading it, it could be where they just do it and get the numbers, and it could be sent on for interpretation even potentially by somebody else. Like, they don't have to even necessarily interpret it, but why would you subject someone to another endoscopy at another time or a high-resolution manometry if you could potentially actually get that information at the index?
Let me give you another version from someone who's not an apostle of flip. And there are some academic medical centers, big esophageal centers like ours at USF, Mike Vasey, I think Ronnie Foss, we don't have endoflip. We do, as I said, high-resolution manometry, and we have time-bearing mesophagram. And see, I'm not looking to do more endoscopy. And in fact, in the state of Florida, and I suspect everywhere, they do a decent job doing endoscopy. What they miss are the strictures that need a real good look at, but they should pick up the EOE and other things. So I'm trying to compartmentalize as rapidly as I can the diagnosis so that when I am doing endoscopy, if I've decided it's going to be achalasia, they're getting a pneumatic dilatation and they're walking away, or if they decide that they want POEMS or surgery, they're done. We don't have to do another endoscopy. So I do like EndoFlip. I like the idea. We're actually going to probably get it for a limited 6 months to see where we're going to use it. But I really am honestly asking myself, how frequently am I going to use it? Now then, in the community, as long as you have the hospital buying it, it doesn't make any difference. It doesn't make any difference, right? The hospital picks up all the money for it and all that. But I do think we need to look at it, and we have 2 armamentarians available. We have 3 armamentarians that give us, if we understand what they show us, HRM, great for pressures. EndoFlip, time-bearing esophagram, great for compliance of the esophagogastric junction. One's great for anatomy. Another is great for secondary peristalsis that equates. And we still have impedance out there that has a large role. So I haven't drank the Kool-Aid. Medtronic hasn't given me a free instrumentation. They are going to finally, after
I need my
4 years,
$75. I'm not giving you anything for free.
Now, if I was getting that deal, I would be in a different situation. But I think for you all in the community, what we're saying is, and the big advancement of Chicago 4 is the realization that manometry doesn't answer all of your questions. And EndoFlip's not going to answer all of your questions, time-bearing esophagram. The esophagus is this unique organ that loves to have a couple of tests to complement each other. And I always feel better when I'm doing invasive things that will destroy a sphincter, that I really do know everything about that esophagus as I possibly can. And whether or not you're talking about pneumatic dilatation, or you're talking about POEMs, or you're talking about surgery, once we get in there and do things, we can't change it. It's done. So I think I'd like people to think about the alternatives also to EndoFlip.
Yeah, and I think, we've pretty much gone through our time, but I think that's the main point here is that, these are not competitive, they're complementary. And there are many times in my practice where I have all three and I still don't know exactly what to do with patients. And in those particular instances, they're quite vexing. So with that, we will conclude. Thank you very much.